or nearly afternoon. So I started just a little early, say hello. I won't start the presentation officially for a couple of minutes while people are still logging in and getting themselves situated, but just thought I'd make sure that everything was working and in good operation. And thank you, John, for your note. If you want to do a little chat in the meantime, get to know some of your fellow trainee attendees, feel free. But I'm looking forward to getting a chance to talk about overvalued ideas. And and my video is working. For those of you that were here from my presentation with Better Health, Better Living a few weeks ago, you know that the video was not yet working. And so, so now you have a little visual on the background as I come to you live from my office at Fordham. And hello, Lori, in rural Georgia, doing good work with the locals in that area, bringing it to the rural areas where I know mental health care is desperately needed as it is all over the country. So welcome, glad to have you here. If anybody's inclined, tell us where else you're coming to us live from. And don't worry, we're just recording it now. So it'll be memorialized for anybody that might view this later. No pressure. Georgetown, Texas. All right, welcome, Sydney. I'm not familiar with Texas. I'm pretty familiar with Georgia. My daughter went to college in Savannah. I've been to Texas to go to Austin. I've not yet gotten to travel much around the state. My guess is through my work with the good folks at Better Living, a trip to Dallas is probably in my future. Not sure when, but it's going to be coming soon. Looks like we have 10 of our registered trainees here. Kelly, very soon. Thank you. Yeah. I'll have to talk to Angela about that. We'll get that happen. All right, so I see it's about noon. Why don't I get started, because we have an hour, and this is a complicated topic, by the way. It's an interesting one too. So just before we get started, let me introduce myself, for those of you that don't know, or as a reminder. So I'm Dean McKay. I am a professor at Fordham University, where I've been for, hard to believe now, for 27 years as a faculty member in their doctoral training program. And I also have the good fortune of getting to work with Better Living Center for Behavioral Health, who are our hosts. I'm on the board of advisors for them, and I'm very happy to be doing these trainings as part of an ongoing series with them. And watch for other events in the future in addition to the list of trainings that are on the site. I'll mention this again at the end. The topic today is on assessing and treating overvalued ideation in obsessive-compulsive disorder. And what I started to say is that this is a complicated topic. It's one from a little bit more of a historical perspective, and it hasn't gotten some of the attention that it really deserves, frankly. And so I want to bring it back, I guess, in a way. And so the motivation for this presentation is to highlight what I think is an important issue, but it's insufficiently discussed in training settings. It does receive still some research attention. And in the service of complete disclosure, I have a couple of students in my lab working on what I hope will be a fairly comprehensive review of the implications of this topic. So let me get started on, let me move my slides. How do I change my slides? So just a little bit stuck on how to advance my slides. Let's see if I make the screen bigger. And give me a moment here as I work out this technical detail. I'm less familiar. There we go. All right, good. All right, so let's do a little history on this. So overvalued ideas. The inherent concept that undergirds this is it has to do with the strength of belief that someone has around something. And I'm being vague about it because in the context of OCD, we're familiar with overvalued ideation in other aspects of our lives. So sometimes and the distinction that we have to draw is whether it has to do with OCD or if it has to do with a very strongly held value. So for example, um, and in the time that we live in the United States, for those of us who I'm assuming that it's all U.S. residents who are registered. Um, if you're a U.S. resident and you know that we live in a country that is very politically polarized, imagine for a moment if you hold a very strong political opinion, how you would feel about being asked to vote for someone in the opposite party. Now, what we're asking you about has to do with possibly an overvalued idea. And that concept, as it applies in relation to other facets of our lives that are very personal and idiosyncratic, is what we're dealing with in the context of OCD. So a little history is in order. The early conceptualization, Wernicke, who some of you may be familiar with from Wernicke's aphasia, comprehensive aphasia, he talked about OVI as an affect-driven, unreasonable thought or set of thoughts that lead to impaired judgment or behavior. That's fairly in line with how we would view it in the context of OCD. Whereas Jaspers was also one of the early psychopathologists who wrote very influential works around how we understand a wide range of anxiety problems. He thought about it really more in the context of like a virtue. So some people who have, let's say, strongly held values that run against some kind of otherwise societal norm, but who maybe are proven correct over time, Jaspers was referring to folks like that. And so the reason why this is important in the context of OCD is that there are many people who have symptoms of OCD where, in discussing it with them, you could say, wow, this doesn't really fit with the traditional conceptualization of the diagnosis, which is that the person says they have intrusive thoughts, and on questioning, they recognize that it is unreasonable. The individual with higher levels of overvalued ideas would say, well, actually, this feels kind of reasonable. I'll give you like a snippet, although I have a case illustration later. There's a guy I'm working with right now who has bad contamination fear. And he talks at length and passionately about things like, he'll go, bro, my phone, if I drop it on the floor, how are you going to tell me that I can go ahead and then put that in my pocket afterwards without washing it and my their data out there, and they should really know better. So that's the issue undergirding OVI, or overvalued ideas. Now, we could think of it as a spectrum. The best and most comprehensive conceptualization of it was articulated by Michael Kozak and Edna Foa in '94. The article, by the way, it appears in an issue of Behavior Research and Therapy. I'm working on getting it so that if any of you wish to have it, I could email it to you privately. My library only goes back to 1995 for that journal. And so I had difficulty getting it. I'm going to have to try and nail it down from someone. But basically, the idea here is that overvalued ideas are towards the end of a continuum that tilts towards delusional processes. Now, that's where it gets really challenging to understand conceptually and how to really distinguish this from simply very anxiety-driven thought, where the threat the person experiences feels like it will be too much for them to tolerate in the context of the kind of treatment that we typically engage in. So on the one side, on the left on this, that's the typical, almost like textbook presentation of OCD. Person has an intrusive thought, they have some kind of ritual that accompanies it that reduces the intensity of that thought, but they recognize that the thought is unreasonable. And as you move along that continuum towards delusion, there are people who will start to say, yeah, but you know what? It's starting to sound more and more like this is a good idea, that my compulsions make sense. And that's what we're up against. And it makes it really quite challenging. So now, its place in diagnosis, it does have a place. Back in the DSM-4, we began to see more and more about OVI specifically referenced. And in the field trials for that manual, which now is about 30 years old, they were assessing it through a process they call fixity of belief. And it led to, at that time, the additional diagnostic specifier of with poor insight. Now, those of you who are on this training and you think about the times that you diagnose OCD, ask yourself how often you think about those specifiers. I don't hear a lot of people talking about it, frankly, and I've on a lot of these different fora where people talk about routinely treating OCD, and I have not heard as much about the specifiers lately. But the original introduction of this in the DSM-4 was that you could say the person had poor insight, which poor insight, it's a loaded term because in other theoretical traditions, insight has a very specific connotation around the process in therapy that might lead to catharsis. So rather different in, and thank you, yes, so some in the comments you'll see that Jennifer Lish, for example, and of all the attendees, I would expect nothing less, Jennifer, than for you to use the specifier. You, I know, are very thoroughgoing, and so so if you're not using specifiers, consider it, because it actually plays an important role in how you are going to conceptualize treatment. And as you're going to see, the ways in which you might approach exposure may be very much impacted by the specifier. The current DSM-5 gives, for all the obsessive-compulsive related disorders, 3 levels of specifiers. One is good or fair, the next one is poor, and then the last one is delusional. Now, that may feel confusing, because if you're saying the client is delusional, you might start really asking yourself if a different diagnosis is going to better characterize the client. And so I'm not a big fan of the DSM, by the way. So let me take a sidebar for a moment. I don't love the DSM. I don't think it does what it accomplishes, what it intends, which is when they talk about diagnoses, it doesn't, I believe, carve nature at its joints. But it's what we have to live with. My feeling personally is that good or fair or poor are probably the specifiers we should most rely on. And if you're thinking delusional, then you might also start to seriously consider a different diagnosis for the person. And the reason why you might consider that, by the way, and it's an important part of this discussion, even though it's not formally included, is that there is a tradition in the onset of different other diagnoses where some of the early signs express themselves as obsessional behavior, the most notable one being schizophrenia. So again, I guess to complete the thought on this, schizophrenia is most frequently the misdiagnosis that people with OCD receive. The flip side is that if you are very good at assessing for overvalued ideas, then you're probably also going to have a good handle on what delusional content looks like. And you should ask yourself the follow-up question of whether or not it's proper to think of this as OCD, or is it better characterized by one of the other delusional disorders or schizophrenia spectrum disorders. Okay, so having said all that, and without it getting too far afield, let's move on. So if you're going to assess this, here's the challenge, of course, right? Assessment means that you're ready to think about the nuances of fixity or belief conviction. So the term of art related to OVI is conviction of belief. And conviction of belief for things that are going to be disabling in the person's everyday life. And so you can start to draw some distinctions that are socially embedded around convictions of activities that are impairing for the person in their social milieu. I'm saying all that for a very good reason, because first of all the available measures are clinician administered. So full disclosure, I was heavily involved in the development of one of the assessment tools that I'm going to describe today. And in doing so, we initially wanted to do it by self-report. An unbelievable failure. People didn't understand it, or we would give it to people where in our one-on-one meeting with them, our clinical impression was that they were near delusional in their belief conviction, but then they'd fill out the measure that we had developed that covered the content, and it seemed like they didn't. And so we concluded that a self-report measure would not be possible. At the time that we developed it, there were two other measures that I'm going to talk about. They were all kind of being developed around the same time, kind of independently of each other. All of them are clinician administered. And you could understand why. If it's a thought disorder process, people who have thought disorder tend not to recognize that they have thought disorder, or at least if they do, they're not good at characterizing it on self-report forms. For those of you in this training who spent any time in settings with people with schizophrenia, and imagine giving any of those clients a self-report tool intended to assess for things like thought insertion or thought broadcasting, you know that this is immediately problematic. But they are embedded in social and cultural norms. And so you as a clinician need to make a judgment call about the suitability for designating someone as having OVI. Let me give two examples, both of which I'm intimately familiar with. One, in Caribbean American youth, we had a child in a treatment trial that I was doing a number of years ago here at Fordham, where the child had what's called a transformation obsession. For those of you on this training who have seen a lot of people with OCD, you may have heard of a transformation obsession. It's usually something where the person says, well, I'm worried if I get a look from a person who I think is not a good person, that I'm going to take on their personality qualities. Things like that are the so-called transformation obsessions. They look a lot like certain delusional processes. You might be familiar with one that was actually the basis for a famous sci-fi movie, The Invasion of the Body Snatchers. Capgras delusion is where the person harbors this belief that the people around them have been transformed into body doubles. And so the transformation obsession is a very specific kind. It can be quite problematic. But the reason why I highlight the Caribbean American youth one is that culturally, this is a commonly held belief due to certain kinds of practices that happen in some of the Caribbean islands. And so the disentanglement for this child, who was at the time 15, being able to characterize whether or not he thought, well, is it possible that a touch from a specific child would lead to a transformation? It's challenging, because the challenge is, okay, here's this person who's upset. When people are upset, they tend not to explain themselves particularly clearly. And then add to the fact that most teens don't necessarily have the most effective psychological verbal description of things. And so our task is to really pick apart that information carefully, but also understand that it comes from a culturally embedded place that allowed us to conclude that that child did not have high overvalued ideas. The other example is that in different religious communities, religious obsessions may be kind of normative based on a conviction that they have around religious practices. So we have to really understand that if the person says things to us like, if I do X, God will disapprove, well, we have to understand if there's a cultural and religious embeddedness to this that juxtaposes with their personal belief system. So you can see how this quickly becomes very complicated. And so we have to understand it through that lens. All right, so now what are the measures that are out there? First of all, you'll all be relieved to know that the three major measures that are available for assessing OVI are freely available. The Fixity of belief scales, you can get the items from that in a publicly available article that appeared in the journal Behavior Therapy circa 1995-ish. FOA et al. FOA was very busy publishing from the field trial. And you'll see that the items, it covers these broad areas. One is the presence of a feared consequence. So the way that works is, let's say the person has an obsession about whether or not they might harm someone if knives are around, And they may feel, even though they do not wish to act on it, they may feel that the risk is very high if a knife is nearby, that they may harm somebody. And so the feared consequence would be one that they feel is very probable, as opposed to, again, the traditional notion of OCD, where any of the consequences the person can say is highly unlikely, but they can't help but feel that it might happen, right? So there's a distinction here that's a fine one, and that's what the clinician has to get at. Then the belief in the consequence. So it's not just that it's likely, but is it something that is not only likely, but that they feel the belief in it is strong. So that's the conviction. The third one then is, how much do other people believe this? That one gets sticky because sometimes people will say, well, this is my thing. Other people don't have this risk, right? So the knives one, other people are not at risk of stabbing other people. It's particularly relevant to me. So if they don't see other people as being at risk for it, their OVI would be actually a little bit lower. How do they explain the presence of that belief? So what are the means by which they understand it happening? That's the explanation. How flexible are they? Do they see any room for alternative explanations? And then the one that, again, probably in this scale, the most, I guess, subjective would be bizarreness. You know, what counts as bizarre for one clinician may not be so bizarre to another. And so this is one that's based a little bit on our own belief systems that we introduce in any assessment scenario. So let's appraise this scale. The benefits of it, it's brief, it's very straightforward. Raters can be readily trained. If you look in the behavior therapy article that describes this measure and its prediction of symptom severity and symptom outcome, it's pretty easy to understand how to do it. And the scaling system of it is brief. It's like a 0 to 4 rating on it. So being able to do it is pretty easy. Unfortunately, the disadvantage is, surprisingly, it was used, as far as I know, only in the DSM-4 field trial and was never really widely adopted. So the interesting thing with this, as I mentioned, in my lab, we're in the middle of really kind of doing a deep dive on this topic. We haven't really found much literature on the fixity of belief scale beyond the field trial. And that means that the concurrent validity data, in other words, how much does this relate to treatment engagement and treatment outcome, pretty limited. And that's really the point of any of these measures. We want to know, to what extent does a score on any of these have an indication for ability to treat and treatment outcome, because it's supposed to be prognostic. So then the second measure for us to discuss is the Brown Assessment of Belief Scale, the BABS. So Jane Eisen and her group, they developed a 7-item scale for this concept in '98. It was validated with a group of people with OCD, body dysmorphic disorder, and then a group with mood disorder with psychotic features. So let's think about, why would a BDD group be part of this sample? So for those of you on this training, if you're really spending a lot of time with clients with OCD, then you probably have, at one time or another, had someone come in who also had body dysmorphic disorder. And body dysmorphic disorder, as a member of the OC-related disorders category, is distinguished by the fact that most people who have that condition believe very strongly. So like the default is that their beliefs about areas of their body that they think are not formed properly, they believe in that very strongly. And so that means that their baseline is fairly poor insight. And so it's an excellent comparison group for an assessment measure like this. And then the mood disorder with psychotic features, it's a nice additional control group for the psychometric development of a scale, because basically, by definition, this is a group that has some delusional processes. And it covers these areas of belief conviction. How strongly does the person believe in this thing that they're concerned with? The perception of others' beliefs. So that's, you're seeing a little bit of a consistency here emerging, and that is that A characteristic of OVI is not just that they believe in it very strongly, it's that other people probably do too. And then the explanation of differing beliefs would be, if other people don't believe it, why? And so the belief in the explanation for why someone might not, it comes into play things like, well, they don't have all the information, they're dumb, they have wanton disregard. There's all these kinds of explanations that I've heard people give that are not ones that suggest rationality. Fixity of ideas, that's basically on the Babs the equivalent of inflexibility. How much do they attempt to disprove the belief? So, the scenario would be one where a person who has high OVI, they would not make really much effort to look for countervailing information. Whereas if someone had, let's say, lower levels, but not at the point of complete reasonableness, they might occasionally have some doubt and say, yeah, I wonder, maybe this is a little bit overboard, the whole thing with hiding all the knives. What if I held one anyway and I happen to know that someone's in the next room? Insight. So insight is, to what extent do they recognize that, well, this is probably a product of a condition rather than the reality of the world. And then there is an item on here that's an outright reference to delusionality. So that point on that last one is kind of the reference item. It's the one that allows you to make a real definitive call, actually know this person has a delusional process and not some lower level phenomenon on the spectrum, the continuum ranging from frank reasonableness to delusions. So the benefits of this particular measure, it's validated with at least one other OC-related disorder comparison delusional group, and developed at a time, by the way, before there was an official recognition of the OC-related disorders category. So little history moment for everybody. If you're newer to the mental health profession as an OCD specialist, so before the DSM-5, BDD was not considered an OC-related disorder officially. It was a somatoform disorder. The OC-related disorders category is new as of the DSM-5. But in the late 90s, there was growing recognition that there were a bunch of conditions that looked a lot like OCD, even if we didn't call them such. And BDD was one of the early ones in that category, by the way. The Babs has been translated to several other languages. I know it's been translated to Spanish. I believe it's been translated to, I want to say Japanese. When I was looking into some of this, I saw that I believe it's been used in Japan. That doesn't necessarily mean that it's been translated. And what's nice is it also has been demonstrated to be predictive of outcome. And in keeping with what we'd expect, higher scores on the Babs is associated with poorer treatment adherence and outcome. Now, poorer treatment adherence means poorer treatment adherence to treatments that have been traditionally used for OC or BDD under ordinary conditions. In other words, with no adjustments for the presence of OVI. The disadvantage is that there, as you noticed in that list, there's a bunch of overlap in the items. And so clinicians sometimes struggle with distinguishing one item from another. So in the Venn diagram of those items, there's a fair bit of overlap. And you might even ask yourself, maybe some of them are redundant. And because of that, administering it is a little bit harder than the Fixity of belief scale. So here's this measure. It's got better data around predictiveness, but might be a little harder to grasp. And like I said, it's out there and available widely. If you are interested in it, I'm happy to send it to you. You can contact me after this training. Okay, so the overvalued idea scale, again, full disclosure, this is the one that I worked on. I was intimately involved in developing the items, collecting the data, and frankly, running the analyses. I did a lot of this work with Fugen Nezaroglu, in the early to late 90s. I was working a great deal with her and her group. And we validated that purely on an OCD sample. So I will mention there were some people in that sample who had BDD symptoms, but their primary diagnosis was OCD. So that's a little like insider note from the data for those of you that are interested. And it covers a bunch of areas. So we ask questions about belief strength, how reasonable the belief is, the lowest and highest strength of belief in the past week. So that's 2 items there. How accurate does the person believe that this is true? The extent that other people adhere to the belief. What is their explanation, the attribution for differing views, and the views of others who hold differing perspectives? Remember, I said before, part of the explanation for why other people may not hold the same views may also get swept up in an opinion that the client has of why other people don't hold the same perspective. I'll make it non-pathological for you to illustrate the point. My wife and I, when we go shopping, routinely encounter other customers in, let's say, Costco, where the behavior defies reason. The one that comes to mind for me that probably illustrates the point clearest is during the peak of the pandemic, when Costco required that anybody entering the store at the New York location that we went to, you had to be wearing a mask. We went by the jewelry counter, and there was someone there who, in order to see the watches, had to lower their mask, as though they somehow needed their nose and mouth to visually see the watch. And to us, the view of them apparently holding a differing belief about the danger of being out in public was, we concluded, well, those people are dummies. And I'm being frank with you, we weren't kind about it. My wife and I, we unvarnished, non-psychologically informed opinion while we were out in public. And that was the way we reacted to it. That illustrates in a nutshell, assuming that you think that my behavior was normal, a normative perspective on what we might be asking our clients. I'll give you one more example. When I illustrated this point years ago to our doctoral students, and I wanted to talk about how people hold very strong opinions, even if they're not necessarily pathological. And the concept that I laid on them was, imagine you go to the laundromat and you have your dirty laundry in a basket. You wash your dirty laundry, and then when you fold it, you stick it right back in that same basket without having cleaned it beforehand. And there were several students, PhD level students, who reacted with horror at the mere idea. And what they would say about why others might do that would be an important kind of contribution to an OVI assessment. All right, so I wanted to put it in a little bit of a broader context for you, but when you're sitting in front of a client and you're assessing them for this, these are the kind of things you want to ask about. We asked in this scale, how effective do clients feel their compulsions are in getting rid of the consequence risk? We asked about insight. Insight as a concept runs through all of this, and that's like, well, what's your perspective on how this belief came about? The strength of their resistance to the belief. You may be acquainted with that if you've administered the Yale-Brown obsessive-compulsive scale. The item related to resistance for obsessions has a very checkered history on that measure, because most clinicians, when they administer it, are asking it from the perspective of whether or not you put up a fight, which then leads to a lower score. The flip side, however, as we may be aware, is if you're treating someone using exposure, you actually instruct them to not fight the thought that much as a way of alleviating it in the long run. And so sometimes people say, I don't fight the thought at all. And on the Y box, that'll earn you a high score on that item. Well, we ask that question too, like, well, how much do you put up an effort to try to counter that belief? It's not really quite the same. And that's, again, an important nuance here. And then the final one is the duration of the belief. How long has this belief been with you at basically this intensity? So some benefits. First of all, it covers a broad range of items related to the construct. When we develop the scale, so again, I'm speaking with my own special background on this one measure that I can't comment on with the other two. It covers a wide range of items related to the construct. We had more, and we eliminated them in the normal course of developing a measure. You always overdevelop items, and then you eliminate ones that are either like performing poorly, or that you go, well, it doesn't really ask it in a way that's clear enough. And I won't bore you with the psychometric details. If you're ever interested in that, if there's enough interest, and let us know, and I can put together a training meeting on just psychometric methods, classical psychometric methods. I am not up on the current ones. We have, from that same group, not as much independent, but from that same group, several investigations demonstrating that it's predictive of outcome involving CBT. Again, in the predicted direction, people don't stick with treatment as effectively when they have higher scores on OVI, and medication. So we have at least one paper that illustrates that medication treatment, in particular using fluvoxamine, better known by its trade name Luvox, that people don't stick with treatment as well, and they don't do as well on treatment when they have high levels of overvalued ideas. Now, I know what you're thinking. I'm going to anticipate your thought since I mentioned medication. Yes, the answer is yes. If high OVI is present, most likely, medically speaking, the prescriber would be well advised to give an antipsychotic. Okay, now, I'm not going to get into a discussion about the relative pros and cons of medication. I'm just going to put that out there. And the other benefit is the OVI has been translated to several languages. It's been translated to Spanish. The lead investigator on this, Figen Nezaroglu, is Turkish. It's been translated to Turkish. It's been translated, as I understand, to a few other languages. I don't have a comprehensive list of those languages. I will say the disadvantage, and this is from me as one of the developers, it can be difficult to administer. The items are on a 10-point scale. Now, the reason why we have it on a 10-point scale is we just felt that 4 points, like some of the other scales, is not enough nuance for what we feel is a pretty complicated and important concept. And we wanted more latitude in the amount of variation on this measure so that we could track it differently as part of treatment, right? We want more nuance in that measure so that we have like a finer grain change rate that we could evaluate. And it can be challenging to score. Now, what I'm about to say, challenging the score, I'm speaking to psychologists and other mental health workers. Now, my own experience with my colleagues has been that adding things and then taking the average is sometimes a challenge. I don't know why, but I think partly it comes from a very strong fear of data. It was never impressed on me so clearly as when I took the licensing exam and when I listened to the preparation materials for the statistics portion, the person speaking spoke as though they were talking to a small child, where they said, when we do research, we collect data. Now, all the other recordings spoke to the listener as a mature, fully functioning adult. And so I'm making a joke here that apparently there's a lot of fear about stats. A little sidebar again for all of you. I have a master's in statistics. And so a way I supported myself in graduate school was helping people with their statistics who were working on their clinical degrees. And I can speak firsthand that a lot of people were fearful of stats. And so this is a challenging aspect. I've been asked more than once about the scoring procedures for the OVI scale. Now, you don't have to do it that way. You could just take a total score. We averaged it just to make the score what we thought more manageable, ranging from 0 to 10, rather than ranging from 0 to 110, because it's an 11-point scale. We thought 110 is kind of a weird range, and so we just thought it made more sense to average it. Okay, so those are our measures. Now let's talk a little bit about what happens in the course of therapy. OVI, if it's elevated, and I don't have really a cut point for where elevation ultimately stands in the way of doing treatments that are evidence-based for OCD, right? There's not really a cut point. And, part of this training is a little bit of a call for research on this. What is the threshold where you can declare exposure might be more challenging to implement. Whenever I do trainings on exposure, if it's in a forum where people can easily ask questions, in real time, face to face, a common question is, can I do exposure with, and then fill in the blanks with some problem? And 99% of the time I say, of course you can. OVI is the one exception where people ask, and I have to then hedge a little bit and say, you have to kind of make a judgment. The judgment that you're making is whether or not exposure will be comprehensible to the client in a way that will permit them to benefit by way of altering their expectancies in contradiction to the feared outcome. And so this is yoked then specifically to the inhibitory learning perspective, and whether or not the person's cognitive processes will be able to ensure that whatever you do in session will translate well to them adjusting their predictions. And so as OVI goes up, the assumption is not secure. And that makes sense, because as you get closer and closer to delusional processes, we know that exposure related to delusional content tends not to weaken the delusion. There's a bunch of cognitive therapy procedures aimed at delusional content. Exposure is not necessarily one of those. It also implies that the client comprehends the timeline to potential consequences. And for some people, if you've ever encountered someone where their insight is kind of poor, they will also not have necessarily a good handle on how long will it take for the feared outcome to be realized if I violate my belief by way of this exercise you're asking me to do. And so those two things exist in quite disharmony with our understanding of OVI. And then in cognitive therapy, we have a similar problem, right? OVI implies that as you get further and further along that continuum, that rational thought related to the symptom is breaking down. And so even if you do cognitive therapy based on the model specifically for OCD, which is, by the way, the one you should be using, where you're emphasizing the specific themes germane to OCD, like overimportance of thought, problems of thought-action fusion, inflated responsibility, potentially perfectionism, all of those, the breakdown in rational thought means that you probably can't address these effectively with people as they have higher levels of OVI. So what should you do, right? So that's why I put it like getting around OVI, because really in some ways, if you think about traditional CBT approaches as you've been instructed to do them, they're frontal assaults on the symptoms, right? Exposure is a frontal targeting of the stated symptoms. You ask the person, what are you concerned about? Let's create a hierarchy, and we start to target it directly, right? And that works, right? It's time efficient, it's straightforward, and if people have reasonable belief systems, very doable. The alternative, though, is to think about OVI as more and more an environmental problem. And as an environmental problem, that would suggest that your target may not reside directly in the client, but in the world around them. And so that means that you might really adopt more behavior analytic models of treatment. Behavior analytic ones rely on reinforcement, desensitization through a process of removal of reward, and other kinds of environmental conditions that are designed to strengthen non-OVI related behaviors. And then the other one is that more and more, if there's high OVI, you're probably going to need to engage the family. So you have two tasks. The person who has high OVI, you as a clinician need to get their rapport, right? You want to engage them around things that are part of their life and their world, and also get them to agree to engagement with the family. And then related to the behavior analytic component, there is an effort to help with the family to understand the client's symptoms, how they can provide reward, and probably also how they can have better emotion regulation in direct response to the family member who's the target of treatment. For those of you that have been around a while as clinicians, you probably recognize this concept. by a specific name. It's called expressed emotion. And expressed emotion, it's a classic concept. Again, one that doesn't get enough airplay in relation to OCD. I'm aware of only a few studies, by the way, that have specifically evaluated expressed emotion as a predictor of symptom expression and relapse in OCD. And those studies have shown that family expressed emotion, which is hostility, emotional over-involvement, which we may understand as accommodation, and depression, those three areas, any one of them in a key family member is going to be predictive of relapse in individuals with OCD. The person who I know, there's a duo that I remember did work on this in particular. It was Gail Steckedy and Diane Chambliss back in the 90s also. So this is kind of like, a grunge era presentation, by the way. So I hope as you're listening to this, you have some Pearl Jam on, or maybe some Nirvana, because a lot of this is 90s era research that is highly relevant and yet not necessarily discussed enough in the treatment of this condition. So Lori, I hope you're rocking out to a little Soundgarden over there as we're talking about this. So the other thing then, given what we're talking about, is there's an aspect that I like to call opportunistic exposure. And so what that means is, remember that one of the items, and I'm going to be a little self-promotional here, one of the items on the OVI scale that I was part of the development asks about how high and how low the belief is over the course of the week. What that suggests, it relates to what we call heteroskedasticity. So those of you that are like stats mavens, heteroskedasticity talks about the distribution of data around a regression line, and it gets to be more variable at some points than at others. And OVI is one of these things where more reasonable level of belief is actually less stable than higher levels. So people who are delusional in their processes have very stable delusional beliefs. But as you go down the continuum and you get to in the range that we think of for OVI, that means it's not that stable. So you may catch this person on a day where their strength of belief is a little bit lower. And on those days, that's the time to try and do exposure. So we're opportunistic in asking about that one aspect related to belief, conviction, and strength. And so that's your aim. So I'm going to illustrate this through an intervention, and then by the end of this, we'll have a little bit of time for some Q&A. So I'm going to illustrate this with a guy named Jake, who, that's a pseudonym. At the time of treatment, he was in his early 20s. This is someone who was treated at my practice, and I was supervising the care. So I did not treat this person directly, but this treatment that I'm going to characterize to bring you out of the 90s, I'll bring you up to like the early 2010s. So it was around like 2010, 11. He had an 8-year duration of OCD symptoms, diagnosed officially 4 years prior to coming in contact with us. His obsession was over bodily fluids. Now what made this a strange kind of thing was twofold. One was he felt that basically semen was emanating out of his body in an uncontrolled way. So it had nothing to do with any kind of masturbation. It had to do with just it's leaking out. And therefore, he could not be in contact with his undergarments and other clothing that may have been like tucked into his pants. But the other thing that made it, let's say, using the Fixity belief scale, bizarre, was he believed very strongly, by the way, that whenever his back was turned, everyone that was around them was aggressively picking their nose. And like he described it to the clinician in a way that was like jarring, that like people were really like trying to get in there, like up to their wrist. And this was happening rampantly everywhere. And then people would go like open the doors. And because of this, because of the concern that he was coming in contact with mucus as well as semen, his showers were very lengthy, over 2 hours a day. He had these odd beliefs about the behaviors of others because it extended beyond. It won't get too disgusting. Tune in for a later training in this series where we get to talk about disgust. I'll keep it minimal since some of you may be on the East Coast and are eating lunch during this training. But he had a lot of odd beliefs about the behaviors of others, all related to bodily fluids. At the time he started treatment, he was taking a very high dose of Abilify, a high dose of Luvox, and a high dose of Klonopin. So what that led to was the sessions with him were the kind where he could not really sustain attention to the clinician if it was a compound sentence. So like if a transcript of the sentence involved a comma, he was lost. So as the clinician said, he had to speak in Hemingway-like sentences. At the beginning of treatment, his OVIS baseline score, remember that's an average on a 0 to 10 scale across 11 items. His baseline score was an 8, so out of a possible 10. And his baseline Yale-Brown obsessive-compulsive scale score was a 26. To remind all of you, if you're less familiar with the Y-box, the highest score you can get on that is a 40. But really anything above a 20 is a very high score and would qualify you easily for most major drug trials and other clinical trials of treating OCD. So what were the first 15 sessions like? So this is not going to be the kind of thing from a, let's say, 10 to 12 session protocol when dealing with someone with high OVI. So most of the early sessions were engagement with the family. The parents had very high emotional reactivity towards Jake. They would get very angry with him, very hostile. They would sometimes do rather extreme things to get him to stop his behavior, usually unsuccessfully. And we instituted contingency management. Now remember, this is a guy in his 20s, but one of them was withdrawal of access to the shower for more than 45 minutes at a time. We had to instruct the family to set up a timer for Jake, and they had to say to him, look, we know you want to shower for 2 hours. We're going to cut the water off after 45 minutes. And it really required a very high degree of commitment on their part. And we had to also come up with some reward for him successfully targeting his own symptoms. So what led to navigating this was to say, look, we know your belief in this is pretty high. You have to kind of trust us on this a little bit. And the clinician did a good job of having him get good rapport. And he said, let's see how much danger you're going to be in, and we'll practice this together. And, and you'll get rewarded as long as you could stick with meeting with me, even just for meeting with me. And so they came up with a reward system. Most of it involved food, and they were making that contingent on his engagement with treatment. So it was very much of a behavior analytic model aimed at helping him to manage this, as well as targeting the family's expressed emotion. Now, what happened in the second 15 sessions? So at the beginning of that, OVI was reassessed. The OVIS score went down. So as he did more of this, and he was forced into showering for a briefer period of time, even if he was trying to get through all of it faster, which, by the way, if you're familiar with this, sometimes when people are given time limits, they try to do their rituals just faster rather than do them less completely. We weren't really that concerned with it. Our main task was just to cut down the time. His OVI score went down and his Y-box score went down, which was great. And as his OVI score got weaker, his conviction got less stable. And the clinician started to do some opportunistic exposure. So what counted as opportunistic exposure? Well, opportunistic exposure included things like the clinician blowing his nose during the session and leaving the used Kleenex on the desk. So just that kind of stuff suddenly changed the dimension of treatment. So even though Jake felt strongly like, wow, you know what, I can't have, nasal mucus in my presence, he nonetheless was able to more effectively tolerate it. And contingency management remained in place firmly. Now, there's another element, a little bit of a sidebar, and again, maybe I'll have to talk to Angela and others about whether or not this would be a suitable discussion, but there's a medication issue here. He was so sedated that it was a little difficult to even have sufficient attention from him. The prescriber, as a little sidebar, would say things like, well, he's not better because it's still really hard for him to get out of the shower. And it's like, yeah, because like he's so medicated, he doesn't remember what he did. It's not even about OCD. So we had to engage with the prescriber around reducing the dosage of medication, in particular the Klonopin, which rather than taking all the time, to take only as needed, and then also reduce the Abilify. The final 15 sessions, and I put final in air quotes because it really wasn't the end of treatment for him. It was the end of super active, full on, gotta manage OCD kind of symptoms. He did so much better. His final, his OVI score got down to a 5 and his Y-box got down to a 17. At that point, the clinician was able to start doing much more structured exposure of the sort that you would associate with more traditional beginning of treatment for people who have low OVI. And the family intervention continued to deal with expressed emotion, right? It's not like people let go of being upset with someone. Here's this guy, 8 years of very bad symptoms, and the family was in acute distress. Better doesn't mean that everybody's going like, oh, we let go of our distress. It takes a little bit of time. A little bit of longer term maintenance, just by the way, about Jake, so that you get the full story. You got another 20 sessions after that where we got to a floor of 4. And he had developmental delays, 8 years of symptoms, and he had to drop out of college. Developmentally, he lost time. When you're in your 20s, there's a lot of socialization that still has to happen. And the current status on him, it's a happy ending for Jake. He finished college. He actually is now currently a very successful business person. But what's amazing with this is that he still keeps in touch with the clinician. And they meet probably every other week. So he's like kind of one of the kind of clients that we're all familiar with, where they kind of need treatment for a long time after the acute phase. He still believes that people are very frequently, maybe not quite as often, but pretty frequently, that people are aggressively picking their nose. He actually really hung on to that one. So with having said all that, thank you very much. It's been a pleasure getting to talk to you all about this, and for you tolerating my 90s era humor. I'm ready to answer any questions you might have. You want to type them in the chat. I will also put in my shameless plug for the next 2 upcoming trainings in this series. The March 20th one, we're going to talk at length about basically what do you do when you're doing exposure with someone. And then on the 3rd of April, how to handle vague future consequences from clients, including ones that, people harbor sometimes about what happens if they violate things related to hell and damnation. And if you want the full list of all the upcoming trainings, as well as the ones that, the one that already happened, you can go to Better Living's website and to their resource shop for that information. So thank you all. I'm happy to take a question or two while we have a little bit of time. I'll do my best to be succinct, given that we have about 4 minutes left. And I will take a sip of my coffee. Thank you, Jennifer. I love the reinforcement. Having Jennifer at the trainings is a guarantee that I'm going to get reinforcement. Jennifer is a behavior analyst in every way of her life. Thank you, Jennifer. Any questions from you guys? I'm happy to field any that you might have. Well, hearing none. Oh, sorry, no questions. Thank you, Candy. Thank you. All right. Well, listen, if you have any other things you want to raise with me, feel free to email me. My email address is mckay@fordham.edu, or you can email me at deanmckayphd@gmail.com. It's been a pleasure getting to prepare this today and get to speak to you all.